Hello everyone, welcome back to the channel. Today we will cover anticoagulation protocols in an easy, exam-focused way. This topic is frequently tested in FCPS, IMM, MD, and MBBS exams and is essential in daily clinical practice. By the end of this video, you will know which anticoagulant to choose, how to monitor it, and how to manage bleeding complications. Blood clots are beneficial when they stop bleeding after an injury. However, clots forming inside the blood vessels can block blood flow and become life-threatening. Common indications for anticoagulation include deep vein thrombosis, that is DVT, pulmonary embolism, atrial fibrillation, mechanical heart valves, some patients with acute coronary syndromes. Remember, anticoagulants prevent clot extension and new clot formation. They do not dissolve existing clots. There are two commonly used injectable anticoagulants: unfractionated heparin, which is given intravenously, rapid onset, and short duration. It requires APTT monitoring, preferred in severe renal impairment and when urgent surgery may be needed. Low molecular weight heparin given subcutaneously, more predictable effects, usually no routine monitoring, preferred for most stable patients with DVT or pulmonary embolism. Example, unfractionated heparin is the anticoagulant of choice in severe kidney disease because it is not primarily cleared by the kidneys. Direct oral anticoagulants. These include apixaban, rivaroxaban, dabigatran, edoxaban. Its advantages are fixed dosing, rapid onset, no routine INR monitoring, and fewer food infections than warfarin. Always assess kidney function, liver function, bleeding risk, direct drug interactions. These are generally not used for mechanical heart valves. Warfarin remains the standard anticoagulant in those patients. Warfarin protocol. It acts by reducing vitamin K dependent clotting factors. Because it takes several days to become effective, overlap with heparin for at least 5 days until the INR reaches the therapeutic range. The target INR is in DVT and pulmonary embolism is 2 to 3, atrial fibrillation is 2 to 3, and in mechanical mitral valve 2.5 to 3.5, and patients should receive counseling regarding consistent dietary vitamin K intake, regular INR monitoring, drug interactions, and recognition of bleeding symptoms. And it is contraindicated in pregnancy because it can cause fetal abnormalities. Different anticoagulants require different monitoring, like unfractionated heparin requires APTT, warfarin requires INR, low molecular weight heparin usually no routine monitoring, DOACs routine coagulation tests are generally not required, but renal function tests should be checked periodically. Always monitor for bleeding, nosebleeds, gum bleed, blood in urine, black stools, and excessive bruising. In patients with major bleeding, stop the anticoagulant, stabilize the patient, and use the appropriate reversal agent. Unfractionated heparin, protamine sulfate, low molecular weight heparin, partial reversal with protamine. Warfarin, vitamin K plus 4 factors, PCC for major bleeding. Dabigatran, idarucizumab, apixaban, and rivaroxaban, and andexanet alpha were available. Always manage the airway, breathing, circulation, and control the source of bleeding alongside the reversal therapy. Now, let us revise Now, let us revise quickly. Remember these four questions. Why does the patient need anticoagulation? Which anticoagulant is most appropriate? And how will you monitor it? And what is the reversal agent if bleeding occurs? These four questions are commonly asked in ward rounds, talks, vivas, and postgraduate examinations. If you remember them, you will be able to manage most anticoagulation cases confidently. Thank you for watching. If you found this video useful, please like, share, and subscribe. See you in the next medical concept video.